Well, welcome everybody. Great to see you. We are lucky enough today to have David Moore from Northwestern University here joining us today to talk about his great work that he's been doing on the crossroads between behavior change, technology, and serious mental health. David is one of the pioneers using mobile technologies, sensing platforms, and suites of applications, and really studying their efficacy with real users who have real problems over time. He weaves this technology into their everyday lives, which is what I really appreciate about it. And I'm going to stop there and let him tell you about it, except for I forgot to say that he's also in the School of Medicine at Northwestern, and he's the director of CBIT, which stands for the Center for Behavioral Intervention Technologies, which is very well known. So welcome, David.
Thanks very, very much. It's really a pleasure to be here to spend some time with Mary and to get to know some of you. So thank you for inviting me out. So I'm going to talk today about. First I'll just give. I don't know how. I'm a clinical psychologist by training, and I've collaborated with people in HCI and computer science and engineering enough to get myself into trouble, but that's not the area that I know that much about. So most of this is going to be from the perspective of a psychologist. So I'll start off with just a few slides to kind of set the framework in terms of psychology. Then I'm going to talk a little bit about kind of a new direction that we have, Mary already alluded to, that we call IntelliCare, a platform of applications, and then talk a little bit about sensing. So, and then I have to mention this, so there's disclosures, so I've had consulting fees from Otsuka and Optum, and then I have an ownership interest in Actualize Health, which is trying to commercialize some of the things that we're talking about. So mental health, most of what I'm going to focus on is common mental health problems like depression and anxiety, but mental health problems are common. So around 20 to 25% of Americans will have a mental health problem in any given year. And the common ones like mood disorders and anxiety disorders, you can see the prevalence rates there. Our workforce is inadequate, so only around 20% of Americans receive what's called minimally adequate care. And believe me, when you look at what minimally adequate is, it is far more minimal than adequate. So, so we have, and if we have about half the number of mental health professionals that we would need to treat people, and we're never going to have enough people. And even if we had them, they wouldn't necessarily be where the patients are. So 90 million Americans live in federally designated mental health professional shortage areas, higher than any other medical specialty. So this is the this is the argument for digital mental health. When we think about treating people with mental health problems behaviorally or sort of with psychological treatments, usually there's some kind of we've tended to use theories that were developed for psychotherapy, and this is one of the most common ones. There are a lot of them, and so this theory, cognitive behavioral therapy, cognitive behavioral theory, starts from the premise that when people are experiencing emotional disorders, we can't reach inside, like with a pharmaceutical, reach inside and change that feeling. But we can leverage the fact that our thoughts and our behaviors affect our feelings are all affected, right? So if I came in here and I were thinking, these people, man, they're really smart, they're going to judge me really harshly, I better do a good job, I would be nervous, it would affect my thoughts, it would make me feel nervous, I might be jittery in my behaviors, right? But if I come in and think, well, they might have some disagreements with what I say, and we could get in some interesting discussions. My whole approach, my thoughts, my feelings will be different, right? So we usually start with a theory. I'm not sure that that's a good idea. That's what we've done up until now, but I just want to put that out there. The other thing I want to talk about is sort of some features of treatment for mental health problems that we should keep in mind when we're thinking about treating mental health. So one is, they're slow. It's not like you take a pill and you get better. Psychotherapy or pharmacotherapy takes at least 4 weeks, even to have the first impact. And psychotherapies often take 8 to 20 weeks. Pharmacotherapy, to get a full response, usually takes several months, and then people have to be on it. So when we think about digital mental health, we're not talking about people using an app for a couple of days. This is something that needs to be sustained over time. It's challenging and it's hard. When people are depressed, they don't have any motivation to do anything. They feel like nothing's going to help. For people with anxiety, they become fearful and they think, oh, this is not going to work, this is not going to work. And so it's hard to keep people on task. And so if you think about people using an app over time, these are going to be really challenging for to achieve that. And so what we end up with in psychotherapies or in treatments generally is we have specific factors like teaching people to monitor their thoughts or teaching people to change their behaviors. Those are kind of the specific skills. And then we have what we call non-specific factors like empathy, warmth, installation of hope that are common to all treatments that try to keep people engaged. Okay? So this is just sort of features to keep in mind that from psychotherapy that might be applicable. So just a brief history of digital mental health. The people started playing with this about 20 years ago as the internet became ubiquitous, and people developed websites. And the websites, the idea was to take psychotherapy and deliver it through a new medium. And so they took some of the components, like in psychotherapy, therapists teach patients things, right? Patients come in, they don't know some things, the therapists teach them things. And so some of the websites, this is an old website that we've taken down, but, there's didactics via video and via text. A lot of forms of psychotherapy have homework, sort of worksheets. This is a common one for CBT. And so those get instantiated in the websites. And then what happened is, as we started to build these things, nobody would use them. So what we did was we put coaches in to try to get people to stay on board. And so there were dashboards that kind of helped coaches understand what the patients were doing to help them keep people on board. Okay, so this is kind of the standard mental health, digital mental health. And there are some people doing more interesting things, but if you look at the commercial world, this is pretty much where we still are. If you think about Marshall McLuhan said, that in any new medium, the first instance of that new medium is imitating the old one. And that's what we've done here, is we've imitated the old medium of face-to-face psychotherapy. At least we've tried to. So we have, and that's taken us a long way. There have been more than 100 randomized controlled trials now, and they've pretty consistently shown that if you just offer it without any kind of support, you get a minimal effect. It's not very big. People tend not to use it. They tend not to stay engaged. But if you add in a coach, you get effect sizes that start to look like psychotherapy, and they start to look like pharmacotherapy. So you can get some pretty robust effect sizes, and your coaches don't need to be therapists. Yeah, human coaches right now. Right, live, and this is usually done with. It can be done. People have done it with email, messaging, phone calls. Sometimes more time, sometimes less. So there's a lot of variability in terms of what that coaching is, and we'll get to that. But I think one of the problems is we haven't really defined what that is. But this said, we have a big research database, and then when you look at implementation, as we've started talking to Kaiser Permanentes and large care systems around the United States and indeed around the world, we see I have not seen yet one single successful implementation inside a care setting yet. They may be out there, but I haven't seen it, and I've seen a lot of failures. And so we have a huge research to practice gap here, which is not uncommon in medicine, but I think that this means that there's some fundamental problems in how we've approached this, and there are kind of a lot of them, and we outlined some of them in this paper here. I'm going to talk about two of them here. One is I think the design has been atrocious, and I'll talk about that in a moment. And then the other is we've ignored the human side, and I'm not talking about putting apps up on the App Store. That's perfectly useful. We've had self-help books for decades in the stores, and people can get those. But I'm talking about designing systems or tools that can be embedded in our healthcare system, which is where I think we're going to actually make an impact. So we've ignored the systems and the human side of it. So the design problems, beating the blues is one of the oldest and still, I think it's still commercially available. And it's basically 50-minute sessions, psychoeducational sessions that teach CBT skills via text and video. It's not badly designed, but people, when you see the implementations, people don't use it. When people are depressed, they don't want to go home and watch a video, 50-minute video every week. You can't get people to do it. That I think is the problem. And there are, others that maybe this is an extreme example, but a lot of them have this kind of flavor to it. So we've developed products that people don't use. And then I think what we do is we go out and we recruit 400 people from the internet, and we find the 400 people who are willing to use the crap that we've built, excuse my French, and then we call that the evidence. So it's not surprising that we can't get the stuff to work in the real world. The development's been top down. It's been people like me deciding what patients need to have, and then we get that to them, and then we try to push them to do what we think they should, and it hasn't fit into the fabric of people's lives. So, one of the challenges that we've been thinking about in terms of starting to deliver tools digitally to people is in mental health we have lots and lots of behavioral strategies. So when a person has depression, you don't treat depression. You don't say, we're going to fix your depression. Ultimately what we're talking about is little components of treatment, right? So we have behavioral activation. So we try to get people to go out and do more positive stuff, right? We have cognitive restructuring to try to help people recognize negative thoughts. We have goal setting, problem solving, lots of behavioral strategies. And some work for some people, others work for other people, some people prefer some. So how do you structure that? And then at the same time, increasingly we have lots of different features in the technology, right? So just for apps, you've got text, you've got video, you've got audio, you've got messaging, you can do tracking, you can you can do logging, feedback. There's all kinds of different ways that people interact. Some people like logging things, some people hate logging things. It's so you can see here that if we're going to design something that's going to help the vast majority of people, you're going to be filling in a grid here that's going to be enormous. And how do you design a system that is going to meet people with the interaction styles that they prefer and the kind of the behavioral strategies? And so what we've started to do is to say, we can't develop an app for this. What we can do, the way that people use apps or tools right now is the little component parts. You don't use an app to manage your entire life. You use an app to find a restaurant. You use a map to map it there. You use an app to book to manage your plane flight. You have little apps that do little things, right? And so what we've done is created a suite of apps. This is just sort of a representation that we call IntelliCare. And it's 13 or 14 apps. And each one is just a single behavioral strategy and a single interaction style. And so the goal is to get something that is, for the most part, can be used pretty quickly. People can open it, they can use it, and then they're done with it. And then there's one app that we call the Hub app that if people download that, it organizes their interaction with the whole suite. All right, so it's just breaking it down into the component parts so they can be flexibly applied to people as needed. Everybody with me? Okay. So this is just an example. So day to day, I'll give you some examples. These are all up on Google Play, and I think the first 3 or 4 of them are up on iOS. So day to day is more didactic, kind of like those old ones. So this is it'll give a brief sort of didactic explanation each week, and then give reminders, sort of messages every day to kind of keep people reminded of that sort of lesson, right? So this is kind of traditional. This is sort of a traditional thought challenger thing. So you go in, you can use, check your, you can identify a negative thought and then find a way of challenging it. But then there are others, like Daily Feats is really pretty simple. You get in, you peg your level of depression. If you're really depressed, you start at level 1, and I got out of bed, I groomed myself, I made good food choices, or I ate something, and I went outside. That's it. And you check those off each day, 4 or 5 times in a row, and then you level up to level 2, and you get another set. You can add some in if you want. It takes 10 seconds. That's it. This app has actually been the most popular app because it's so simple. And so I thought nobody's ever going to use this. When it was one of my developers thought it up, and this one gets used more than any of them. Because it's simple. This one uses images a little bit more, so you can take a photo, add a mantra to it, and it loads and it reminds you of that mantra periodically. That's all it does. So there's a lot of these. So we've had, since over the last 2 years, from Google Play, we've had about 80,000 installs, 76,000 unique users, and as of a couple of days ago, there were 10,000 active users, meaning that they've used one of the apps over the last 30 days. So it's been working pretty well. If we look at a benchmark, one benchmark that's been used for health apps is, most people download an app and you maybe open it once and never look at it again. So this was a diet app, and 2.6% of people used it more than 10 times. So by that, around 5 to 35% of the people that have downloaded an IntelliCare app have met that criteria. And so you can see here, across all the apps, on average, they're used about 13 times over the course of a month. The daily feats, our top one is, used 27 times over 45 days on average, day to day, over 38 days. And then all the way down here, this one is so much of a dog, we've pulled it off. We haven't been able to fix it. So some of these others here are not, need more help. And I should also say we've been iterating over these. So after we put them up there, we got feedback. We'd get people to give us feedback, and we made changes until we ran out of money, and now they're up there the way they are. So we also have done a trial. So we've done 2 trials now. I'll talk about the first one. The second one, we're just starting to analyze the data. So this is just a first field trial with 100 people, and so this was starting to look at how do you put this into a care system with coaching. And so we enrolled 99 people who had the PHQ as a measure of depression and the GAD as a measure of anxiety. So these are people with elevated levels of depression or anxiety where a physician would refer them for treatment. And so this is the dashboard, and there's this here is the apps when they've been used and launched, and if the care manager clicks on it, it gives them a little bit of information. This manages the text messaging. This is the apps that are installed and the apps that are being used, and then this is their sort of history of symptom severity. So this is all that the coaches get, and they had a 30-minute phone call with people to get started, and then over the 8 weeks, they just use text messaging back and forth. And so this is the reduction in depression and anxiety that we saw. So it's substantial. Viewed another way, for depression, everybody started out blue. So they all had significant levels of depression, and at the end of the 8 weeks, 37% had no symptoms of depression at all anymore. 40% had dropped below the threshold. They still had some residual symptoms, and 22% still had symptoms that needed treatment. So these are good findings. We were pleased with this, and we've currently just finished a randomized trial, and the outcomes are looking very, very similar. So how might this work? Why might this be working? Well, I mean, at a simple level, people are using the apps, so maybe that's helping, and they're getting coaching. So those are the 2 pieces here. So let's look at the app use. So the average app launches over 8 weeks were 195 app launches, and if you're familiar with kind of, that's a lot. And typically when you what per person over 8 weeks, yeah. And just in those 8 weeks. And when you look at app use for these interventions, typically you get kind of a hockey stick, right? You get people, they start off using it, and then in the first week or 2, they drop off and it gets low. Here what we see is people are consistently using launching the apps 3 or 4 times a day throughout the entire trial. And in fact, 2/3 of them continued to use them after the trial ended. And so I think the reason that we see that, there's one is that the average time that it takes is a minute, and the median is 17 seconds. So we have a bunch of apps that are like the checklist that they just take a few seconds to use. They're simple. And then there's a couple that are longer, like there's some relaxation, so that takes 5 minutes, 10 minutes, depending on the video. But in general, they're simple to use, so they can fit easily into the fabric of people's lives. The other, I think, is that the idea, and I hadn't thought about this when we designed it, but people are getting new apps. They use the apps for a week or two, and then they use another one. And so it's not like staying with the same app. There's novelty involved. And so they're not necessarily getting sick of doing the same thing over and over again. So then I want to go back and talk about use. So you've already seen these data. This is from the public deployment. So this is fresh data, so it's it's not exactly comparable, but you can see here that for the apps, these are the mean here is 27. With the coaching, it was a median of 29. So it's not exactly the same metric, but it's sort of you can see this is in the same ballpark, right? So the use patterns, once somebody has it on their phone, the use pattern within any individual app is kind of the same, which is surprising. So the coaches aren't necessarily getting, once the app's on their phone, the coaches aren't really getting them to use it more, necessarily. But what you see here, up here, is that people are using more of the apps. The coach is really able to get them to use more of the apps. I think in the public deployment, 2/3 of the people only use one app, and 1/3 then start using a number of them. And it's mostly the people who download the Hub app who end up using more of them because they get recommendations. So recommendations maybe increase app use, and this is just the data from the people with the Hub app on their phone, and they end up. For these different apps, they end up, if a recommendation automatically is launched, it increases the likelihood that they're going to use that app by this amount. Yeah.
So your individual apps don't recommend any of the other apps? Just the Hub recommends the children?
It all goes through the Hub. And so the Hub, thank you for asking that. So what the Hub does is it monitors what's on the phone, and then it will make a recommendation. Each week it'll recommend a new app. Initially we just did it randomly, and we've recently put in just a commodity recommender engine that increases I'll show you, it increases it slightly. But we think that where we're going with this is that we think if we can start to learn how to recommend it, we can start to increase, increase the helpfulness of those recommendations.
Was there a reason that you don't have each individual app all at the end say, and check out our other apps?
No, there's no good reason for why we did it that way. Honestly, I think we were just trying to figure out how to get this out and launched. So we didn't have, we had the Hub app do a number of things. Once the Hub app is on the phone, it manages the recommendations. It then manages all the notifications. So kind of everything then goes through the Hub app. It also, I think it's probably in dire need of some redesign because it's the thing that people complain about the most. So it's not the best way to do it. But along those lines, when we look at these apps, looking at app use, they fall into clusters. So people who use Day2Day or iCope or MyMantra, if they use one of those, they're more likely to use others, right? And they fall into, I think 4 of these seem to make sense. So, the first column there is language, or they use sort of, it seems like they're engaging people cognitively, so it's sort of a psychological method of engagement. The second one, the Purple Chill, is the relaxation app, and Slumber Time helps people with insomnia. So kind of relaxation apps, then apps that rely on checklists, so that's more kind of interaction style that seems to be holding it together. Activity Boost Me is kind of behavioral activation, so getting people to do more positive activities. Move Me is getting people to do more physical activity, so those kind of hang together. So these make sense, and then these are just the worst apps that we have, and I'm not sure. I'm not sure analytically what's happening, but they're our junky app. So you can see that I think that we can start thinking about having a recommender engine that can drive, essentially be kind of a Netflix for mental health apps that can start, directing people to apps that they're more likely to use. And we're doing this in the context of IntelliCare right now. So we're working with some people at Columbia, some biostatisticians and machine learning people at Columbia who are doing the analytics to try to develop a better system for this. But you can also imagine that this kind of analytic system could be used for any apps. They don't necessarily have to just be ours, but you can start to have a platform that can begin to provide guidance to people for the, I don't know how many hundreds or thousands of mental health apps that are out there on the app stores. So that's kind of one direction that we're going with, with the design here. So, maybe we don't really need care managers if we can get people to use the apps, right? And I still think we do, and there's two reasons. One is I don't think healthcare settings are going to want to host apps as a form of treatment. They're in the business of providing services. And I think that we have to start thinking about how we can use digital technologies to improve their ability to extend services. And then the other is that I think we still, in the work that we've done, we have some biased samples, right? We're recruiting people who want to come in and be part of a study. These aren't your average patients. These are people that just the fact that they're in our study, they've already demonstrated that they're more motivated than the average person. That's pretty different than having a care manager say, I think you should do X, Y, or Z. That's going to be that you're going to get a whole different level of people. We know that patients, 50% of patients don't even take the medications that their doctors recommend them. So we're dealing with, I think there's still a huge role for care management, even though it looks like we're doing well. So, I described the coaching that we did, 30 to 40 minutes of call time, 20, 25 text messages. And when we look at the text messages, they fall into like 10 or 15 different buckets when we cluster them. One is opinions about the apps. I like this, I don't like it. Picking which app to use, making a decision, technical problems, sorry, responding to the coach, sorry I didn't get back to you, blah, 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 excuses, scheduling, etc. Things are going well, yes, no, and thank you, right? These are pretty well-defined buckets. And so when we start looking at the coaching, a lot of this could be automated, I think. I don't think care systems at this point are ready to turn it all over to something that's automated, but and you'll see in a minute, I think providing automation can really help care managers, because care managers in these systems are not necessarily trained in managing mental health problems. Yeah. So,
and those are the general buckets. Do you get ones that are like, I can't go on today, please help me, calls for help type thing?
I think we will. So we, in these early studies, we screen people out with significant suicidality. There are people who have some suicidality, so they certainly having suicidal ideation is part of it. And we do get some people who talk about those, who will raise it. We did not have any of those 100 people say, I'm going to go out and kill myself, which does happen in some of my studies, but.
What about...
so then we call them up and we usually talk with them and assess them.
That's interesting. I'm also curious about just in general, maybe not suicidal, just, I'm having so much stress about my job tomorrow. Not suicidal, but just needing more help as far as dealing with anxiety or calls for help in that sense.
Yeah, I mean, what I haven't presented here was kind of the development of our care management model, and we also didn't get that right first. So when we started out, as we were going through and talking to the users and the care managers, there was a lot of lack of clarity of what the role of the care manager was. So one of the things that we had to do is make that pretty explicit up front that this is not therapy, and so still people brought up things like a death in the family, or significant stressors that and so when those came up, if it was significant enough, they could arrange for a second call to talk with them for a few minutes to try to connect them with other services that might be more appropriate or like that. They didn't get into but the care managers did not get into helping people solve specific problems. They didn't go over the line into starting to do psychotherapy, and the reason for that, I think, is that we're anticipating that the kind of people that would would manage a system like this, care managers, typically don't have a lot of mental health training. So you're going to need a system that can kind of have a defined set of goals for those managers. Does that kind of answer your?
It does. So, so it sounds like you've gotten some of those. Are those a lot less than these? So you wouldn't assign the category to those type of incoming texts?
You know, I would have to go back. So these we just got from somebody that did our NLP at University of Washington yesterday. So I put these in last night.
Okay.
So I don't. I don't actually know what happened to those sort of random ones that didn't fit in everywhere. So, sorry. But yeah, there are. But I think that's when we anticipate kind of how a system like this might work. What I anticipate is I don't think in a care system right now they would be comfortable with any kind of message going out to a patient that hadn't been vetted by a human. I think that means in any kind of care setting. Maybe we'll get there, but I think most care environments right now that's a step too far. But I think what we can do is give care managers, send this message, have them look at it and send it, and then have the ones that are like you're describing, that there isn't an automatic response. Here's something. Here are 3 different levels, or here are 3 different types of responses you might give, or contact somebody for further assistance on this. But essentially providing in the same way that we're trying to give patients guidance. I think we have to give the care managers guidance.
One of the things we did in Puckets, because I think this is what Kale's getting at, is right off the bat they have to give us a rating on how suicidal they feel.
Mm-hmm.
And if it goes over a certain number, we have the trigger. Like, we know exactly what the response should be. So like, call 911.
Yeah, and you're dealing with a
Yeah.
population there that is really very suicidal.
Yeah, so we're always super concerned about it.
Dealing with suicidality in the context of primary care has been each organization we have to negotiate that differently, because they, obviously when you go into primary care or sort of medical settings, nobody wants their patients to commit suicide, but they physicians want, they don't have time. What they need is, this is what you need to do. Here's a yes, no. This person is suicidal. You need to refer them. You need to get them help. This person is not. And it's really difficult in these systems to get that level of clarity. So we end up, for example, when we were working with Northwestern, one of the outpatient clinics in Northwestern, we didn't assess it. They did not want us to assess suicidality. They were worried about liability. So we screened them out. We assessed it right at the beginning, and we just screened people out who had high levels of suicidality. Other places, they do want that information, and they have somebody tasked with, who can do that outreach. So it's really, again, this is where I think, a one-size-fits-all system is not going to work in our care system. When you see one care system, you've seen one care system, and there's a lot that doesn't translate to other care systems. So I think these kinds of tools are going to have to be adaptable to the needs of the individual systems. So what we've done, and speaking of that, what we've started doing is realizing what we have to do if we're starting to think about designing tools to go into a care system. We have to design for the patients, obviously. We have to design for whoever's going to manage it, but we also have to design and understand the care system. So we've just now starting to work with 3 different care systems. One is Northwestern Medicine Physician Partners, which is an arm of Northwestern Medicine that is building out its value-based care. So they take essentially like Blue Cross Blue Shield contracts. They don't do fee for service, and they're buying up practices from Lake Michigan out to the Mississippi River. So they're sort of in this expanding their footprint. And they need to be able to manage mental health problems. This is a huge problem for them because they don't have capacity. And if you get out of the greater Chicago area, there aren't any providers. And we've been talking to Rush, which manages a lot of low-income clinics around Chicago. And then we're talking with University of Arkansas, their medical care system, which manages a large rural population. So we've started doing some initial design work with, Madhu Reddy. Yeah, so we're working with Madhu, who's kind of leading up a lot of that. And so I'll just give you a flavor. So we started with Northwestern Medicine, and did a lot of interviews with people in primary care clinics and quickly realized it was never going to fly. There was no way that we were going to put this into a primary care clinic because there's no bandwidth, nobody has time, they don't have the expertise. So that's where the patients are, but there's no staff that can manage it. And what we realized is that this organization, a lot of organizations are developing these sort of centralized care systems, and Northwestern Medicine is. So it's a centralized care management system where they're getting, when physicians make referrals, they're making sure that patients get there. So they'll call them up, they'll work with them. When they have problem patients, they'll stay engaged with them to try to make sure they get the care that they need. So these are people that are delivering their care remotely, and they're often dealing with patients that are kind of difficult or that have problems. So we realized that's probably the place. So we've done a first round of detailed first round of interviews with these care managers, and we found a number of barriers, problems. So they don't see their role as managing mental health necessarily. They manage medical problems and lifestyle problems, obesity and so on, but they haven't seen mental health as part of their what they do. Honestly, they don't really know what their role is because they're developing it and it's kind of a chaotic system. But most of them have no training in mental health. But on the plus side, more than half of their patients, when we go into the medical records, more than half of their patients have significant levels of depression. So this is a population where that's a huge problem, and they recognize that the depression interferes with their ability to get other things done. So if they have diabetes, they know that the people that are depressed have a harder time managing their diabetes. So they recognize it as a problem. There's a lot of barriers to mental health referral. So either long waits or just lack of availability, and they see they actually see this type of system is potentially beneficial. So rather than going into a primary care where we have to find somebody and tell them to do something in addition to what they're already doing, here we could potentially develop a system that can make their jobs easier. And if we can develop a system that makes somebody's job easier, it is much more likely to be implemented in a sustainable manner. So far, in this setting, they're very enthusiastic, and we're starting to do the same work with Rush and with the University of Arkansas Medical Center. So that's kind of, I think, yeah, okay. So briefly, so I think what we're looking at here is, the primary care is still, the doc is still the primary person that is connected to the patient. Specialty mental health may or may not be available, but we now increasingly have these care managers, and if we can put something in the center there that can manage communications between those, that can help monitor the patient, that can provide support, and we may be able to get something that actually is sustainable and workable. I'm going to skip through this. This is sort of the summary, but in interest of time, I want to get to some of the sensing stuff because I wanted to talk with some of the people here about that. And just briefly, you can think about these digital mental health tools, particularly the skills-based ones, as little feedback devices, right? So they get information in, they process it, and they provide that information back to the user in some way that's hopefully useful to them, provide some insight, some motivation, right? And the problem that a lot of users encounter is putting the information in, right? We've all probably downloaded apps that we think is going to be great, and then we use them for a few days and get sick of entering the information and uninstall it, right? So that's where, potentially having some way of acquiring those data, like, in the same way that we can get step counters now have made a big impact on people who want to be physically active, it may be helpful. So just a little bit of the work that we've done. This is when we started a few years ago. We developed an app, Purple Robot, that could pull the sensor data off of Android phones. And this is our first. Mostly we did this to try to debug the software, but we enrolled about 30 people, and there was a pretty good range of depression. And so this is 2 weeks of data, and these are some clusters from GPS that we got. Some features from GPS features, and so you see here location variance. The variety of places a person goes was pretty strongly related to their level of depression. So people who tend to go to the same place all the time are more likely to be depressed. But novelty, people are less likely to be depressed. Entropy, if you spend more time, if your time is distributed across places, more evenly, you're less likely to be depressed. If you tend to spend most of your time at home or at work, like it says home, stay there, you're more likely to be depressed. And the one that I was particularly interested in here is circadian movement. So this is, people who tend to be more rhythmic in their movement through geographic space, they were less likely to be depressed. So it seemed that mood would pull people off. So this was interesting. So we thought, could be just chance. So we got another data set from Andrew Campbell, who had collected the student life data set and ran the same analyses. So these were about 50 students who, they got their PHQ-9 measure of depression at the beginning of the semester and at the end of 10 weeks, and then collected their GPS data over those 10 weeks. And what you see here is at baseline, the number of places that they went, location variance, and circadian movement were significant. Not as high as in the first sample, but they still remain significant. And then at the end, there was a pretty broad correlation. A lot of different GPS features were related. So the general idea that movement through space was related to depression seems to be confirmed. Yeah.
Sorry, what was this? What happened between the 10 weeks? What did you have people do differently?
Oh, they went to school. These were students at the beginning of their quarter and at the end of the quarter.
Okay.
We didn't have them do anything, or Andrew didn't have them do anything.
Okay.
It's just regular life. So we looked at. So one of the things, I don't have a slide on this. One of the things that I wondered is if this is really true, then probably we would see stronger effect on weekends. Because during the week their movement is less under their own control. They have to go to class. They have to do this or that. On the weekends they're free, and indeed we saw for a number of these features they were stronger on the weekends. Another thing we looked at was if at the baseline depression, does that predict movement? So if you know how depressed I am today, does that tell you anything about how I'm going to move through geographic space next week, 5 weeks from now, 10 weeks from now? And it's largely what we would have expected. So, at the same measurements taken at the same time, there was sort of a modest correlation, and that all went towards zero as time went on. And then we looked at it the other way. So the GPS features predicting depression 10 weeks later. And what we were surprised to see, I was surprised that there's no change. So how people move through geographic space tells you just about as much about how depressed I am today as it does about how depressed I'm going to be in 10 weeks. And another slide I should have had, is the amount of change in depression. And these people went up and down. So there's a lot of movement in this sample. And they're students. They're not necessarily all mentally doing fine. So what this suggests here is that that how we move through geographic space may be an early warning detector for depression. Before people start having symptoms, one of the things we might see is social withdrawal or changes in patterns of movement. At the same time, we published our first article. Fortunately, Micro Musalesi was doing the same thing at UCL in London and found kind of similar features. We were fortunately, the one time in my life I actually didn't get scooped. We got published a month before he did. There's another group in Oxford that did the same kind of thing. These are actually using our features, and they did it with bipolar patients, and they could predict depression. So this is looking good. So we got our first study, then we replicated it. Now we've got independent people. So we did another study that where we got 211 people from around the country, in different people. We collected this over the space. They were enrolled for 6 weeks, and we got their depression at the beginning, at the end, and tracked a bunch of different stuff. And it got nothing. And so we thought, well, maybe it's, this was done over the winter. Maybe, maybe it's, going out doors in Minneapolis in December is different than in Miami. Maybe we had a broader range of people. Older people move differently than younger people. We looked at a lot of this stuff. It looked like younger people, we got an effect. But a lot of this, we just got no significance. And you know, was very disappointing, but yeah.
So don't you have a baseline or control for these different people so that you can compare, you know, what other people in Minneapolis or in the winter are doing compared to these people, so that you have some sort of baseline of non-depressed people? Because you're right, it's probably different from in warm than in
Well,
cold.
we did have, so this, I should say, this group was roughly divided into quarters. So one quarter was had high depression and high anxiety. One quarter had high depression and no anxiety. One had high anxiety and no depression, and there was one quarter that was healthy controls.
Okay. So when you compare against the baseline of the healthy versus how much more or less you were with,
We just didn't see anything.
Didn't see anything, huh?
Yeah. And I think I don't think this.
Coasts versus the Midwest.
We did not. We looked at. I mean, there's probably ways that we can do this and try to look at this more carefully. There's a lot of issues in here. I don't necessarily believe this is the final story, but I think what this does is the message I think that I'm getting from this is that this is a much more complicated issue than we thought initially. So the other studies are small. They tend to be geographically defined in a small area. You know, a narrow scope of people, and I'll talk about this in a moment. We can talk about it now. You know, I think what we're dealing with is just an enormous amount of variability that you have to manage. That you've got differences in how people use their phones, in weather, in, you know, health, in age, in, I mean, just a huge amount of variability that, you know, any small study. I mean, all these studies are 10 or 30 people, mostly done with students, you know, and CS students, probably not general students, you know. So the you know, when you move this out, and a lot of the studies also, you know, I think that part of that is that in CS, you know, to get published, you have to do something that nobody's done before, and so it's not, you know, replicability is not, that's not highly prized. But in public health, we have to have things that you can replicate, and so, you know, I think there's a lot of room where we can work together in this, but it's not going to be simple. So I think we're almost out of time. So I'm just going to kind of wrap up. I mean, what we're doing here is what we're doing now is we just got another grant funded to extend this, and we're starting to extend this work, and we're partnering also now with UCLA. So UCLA has a large project that they're starting called the Depression Grand Challenge. So their goal is to enroll 100,000 people and track them over 10 to 15 years with everything, genetics, all kinds of stuff, because they want to solve the problem of depression. That's the goal, and this is kind of at the highest level of the university that they've made this initiative. And so we're working with them to try to start doing this kind of sensing, you know, to get this sensing in. So over the next year or two, they are planning on enrolling around 10,000 people, and we're going to try to get this, you know, get at least for a large segment of those people, get software on their phones where we can pull the data off. So that's kind of the direction we're going. And I think to solve these kinds of problems, that's what we're going to need to do. They just also say that what we did get out of this are things like we could in this sample of 10, we could see when people woke up and when they went to bed and when they got up within a 10-minute window, and we could get that with around 90% accuracy. We could get the relationship to their contacts. So was it a friend, a family member? You know, because how you text and phone is different with those different categories. We could predict that. So I think that, you know, there are things that we can predict more reliably, and I think those are going to be behaviors that are more proximal to the phone sensors. Like if there's a direct line from the sensor to the behavior, it's probably going to be easier or more reliably detectable. If you get things like depression, which is vague and, you know, expressed very differently across people, it's going to be a lot harder to get reliable detection. So I'm going to end it here. So just say thank you to a lot of people, because this wasn't just my work. This is a lot of people. So thank you very much.
makes you feel better. In pop therapy, we found closeness to home and closeness to work were the two most highly predictive features in the machine learning model for how depressed someone was going to be. And it went both ways. Like if you loved work, then it was a super good predictor of you not being depressed. If you hated your job, it was a super good. But so we saw some location-based information too.
Yeah, I think there's something there. You know, and it's interesting because I don't think we've ever been able to really track it that well before. There was a guy. So I've sort of started looking at, you know, some geographers have used this, and there's a guy in Israel. I'm trying to remember his name. Noam. I mean, I can dig it up. But anyway, he's been funded like by the Israeli Tourist Board and the Italian Tourist Board to use sort of sensing for all kinds of things. But he's interested in mood, and so he had this great study in Jerusalem where they got like 5,000 tourists, and they were collecting their GPS data. I think they got some kind of GSR sensor, you know, like a wrist-worn sensor, and then they got their mood. And he created the mood map of Jerusalem. And it's like, you know, you can see like elevations that are reflected across all of these as people get close to the Wailing Wall. And I mean, it's just really amazing how like the geography of that city can impact people's moods. And so I think there's a lot that we can learn. People's rhythms are reflected in it. That's other questions or comments or critiques?
So when you talk about the collecting sensor data from the phones, is that specifically about location? But going forward, do you have other data?
Well, we've collected. What have we collected in that last study? It wasn't just GPS. Certainly call. I mean, this was done on Android, so we got call and text logs, light. So like the sleep wake, time was a big factor. You can get a lot just knowing when people go to bed the first time because people are fairly consistent. But you know, also like sound, light was a factor. Use of the phone. So we had a bunch of them. We did not get accelerometry because that just burns up the battery. And you know, we're trying other little things like maybe if we can turn all the sensors on for like 30 seconds periodically during the day, that'll give us a sort of a burst of data that would be useful. I don't know, but those are the kinds of things that it might be helpful to talk with you about because you've been thinking about these things.
All right, no more questions. Let's give another round of applause.